Welcome everyone to our event today. We are closing the capnography gap. My name is Dr. Zipporah Gaduya, and I have a wonderful group of people to discuss this. Today we are going to have language interpretation into English, French, and Spanish. To ensure that you hear all of today's discussion, please can everyone, including the English listeners, head to the interpretational globe icon on your Zoom screen and select the correct language. Depending on the gadget you're using, you might see it at the bottom as a globe, or you may have to click on the More button and then go to interpretation. We have just one short hour together, so I'll give everyone just 1 minute to get to their rooms. I hope everyone can hear me clearly and you're able to get to your language room so we can start. Great. We have just one short hour together, so I will not be giving individual bios for the speakers. You will find those on the chat. And if you have any questions, you can also put them on the chat. And our hosts, Lifebox and Smile Train, and the World Federation of Societies of Anesthesia are here with us. And so we are off to the discussion. We'll have Dr. Enright kick off our discussion. Angela, could you kindly tell us where we are at and how, in terms of capnography on the group? Angela, welcome.
Okay. Hello, everyone. Can you all hear me? I hope so. I'm going to speak quite fast, so please be patient with the translators as they struggle to keep up with me. I want to show you this picture, which is from the United States, and it's a graph showing how many suits came to the Closed Claims Project before the introduction of capnography. And here you can see where capnography was introduced and see how few lawsuits were coming because of patients having unrecognized esophageal intubation. The point is that capnography really changed what was happening. And as a result of this, capnographs and capnography became mandatory in most high-income countries. But if you look at this picture from Guatemala, you'll see that, sorry, this one is from Kenya, but it does show the same thing, which is that in capnography, there are very few capnographs available in the operating rooms of Kenya. Here, very few, hardly any available in the recovery rooms, and very few available in the rooms where procedures are done under sedation. It's very important to have capnography available. And here I'm going to show you what happened when capnographs were brought to Malawi. This was done by some of our British colleagues who brought 40 capnographs to southern Malawi, trained people how to use them, and then asked them to maintain logbooks documenting what they found when they used the capnographs. 6 months later, they went back, and here is what they found. And you can see here, in particular, esophageal intubations were very common, and also breathing disconnections. And this is vital if these are discovered in order to save patients' lives and to save them from great morbidity from hypoxia. So the point is that capnographs are essential in saving lives. And our colleagues in Britain calculated, based on the population that they were dealing with in southern Malawi, that there would be 11, almost 12 esophageal intubations per million population per year. And if you extrapolate that to sub-Saharan Africa, it's possible there could be as many as 11,000 esophageal intubations occurring every year. So you can see how really important it is to have capnography available to help people make that diagnosis and to manage the patients appropriately. And so we come to having this wonderful little Smile Train Lifebox monitor, which can help us all save lives. The key points are that capnography is the key to diagnosing esophageal intubation. It's the gold standard. It provides a lot of other information, particularly about cardiac, circulatory, and metabolic systems. And we all need to be able to use pulse oximetry and capnography to monitor patients. So I'm going to suggest that what we need to do is to develop a coalition for capnography. So we have our leaders here with Smile Train, Lifebox, and the World Federation of Societies of Anesthesiologists. But we need to get all societies of anesthesiology involved and advocating for this. We need to get the World Health Organization. And when the World Health Organization and the WFSA are upgrading or updating their safety standards, it's time to make capnography essential monitor. They've avoided saying that up to now because there wasn't a monitor suitably priced and suitably made available. And now we have a monitor that is suitable for use everywhere in the world. We need to get other big organizations like the Patient Safety Foundation, the G4 Alliance, Global Surgery, donors, industry, NGOs, universities. We need particularly to get surgeons involved. Most surgeons don't appreciate how great a monitor and how important a monitor it is, with perhaps the exception of surgeons who are working on cleft palate surgery in small children, where they are very aware that disconnects can occur, that esophageal intubation can be easy to do in those patients, and that extubation can occur while they're working. So those are surgeons who really appreciate this monitor. We need to get intensivists involved as well. And so what would be the pitch that we would all make? I think we need to say we have a great affordable capnograph. It's been proven to save lives. And we need to frame it as a surgical patient safety initiative, not just an anesthesia patient safety initiative, but a surgical patient safety initiative. What are we waiting for? Capnography is now in reach of everybody. It's all about patient safety, and we all need to be part of the solution. And that's it from me. Zippy, back to you.
Thank you so much, Dr. Enright, on emphasizing the capnography gap and how important capnography is. I'm now going to ask Dr. Evans to highlight the work that has gone to making this a reality that we can bridge the gap. Dr. Evans.
Thank you, Zippy, and thank you for this opportunity. And thank you to our audience for taking the time to kind of come and join this really important discussion. You know, over the past decade, numerous efforts have really been done to characterize the shortage of various pieces of anesthesia equipment in low and middle income countries. But really, up until recently, most of these efforts have been focused on pulse oximetry, and really for good reason. Pulse oximetry is relatively inexpensive, easy to use, there's low maintenance, and considered really essential by all existing national and international guidelines, including the WHO, WFSA standards. And perhaps one of the few benefits I could see from COVID is that now people around the world, even outside the healthcare landscape, know what a pulse oximeter is and really, I think, understand its value. Unfortunately, capnography is a little different. It wasn't really until just a little history, and this is to build on what Angela said. It wasn't until 1986 when Harvard Medical School published their standards for patient monitoring during anesthesia that really the monitoring of end-tidal CO2 was seen as a standard and really strongly preferred. And it wasn't until the early 1990s that most professional bodies in high-income countries included capnography in their minimum standards for anesthesia. And you can start to see from the data that Angela showed you the impact that that had. However, we also know that capnography is not so familiar to the general public, or actually even in some ways to our fellow healthcare providers. They know what it is, but they don't really understand it. And one of the challenges we've had is it's kind of used in fewer healthcare locations than pulse oximetry. We see it being used in the ICU, the OR, and we see it being used for procedures requiring sedation. So the intensivists understand it, the anesthesia providers understand it, and the proceduralists using sedation understand it, but not everybody else really does. It's also more expensive, more challenging to maintain, and it's pretty uncommon in many of our low-income settings. And that's what we're here trying to change. As previously mentioned also, it's only considered, well, actually, Angela didn't talk about this, but it's only a recommended piece of equipment on the WHO WFSA standards. And you might ask why. Well, not until now do we have what we think is a cost-effective, resource-appropriate solution. The SmileTrain Lightbox dual parameter device that actually I need to highlight includes both capnography and pulse oximetry. I think not everybody recognizes. So really to get to this point, several critical steps have occurred that I think are really worth highlighting. Prior to this work, and really the recent work, there were several groups working on a capnography solution. And I just want to highlight all of these groups because I think what they were doing was critical to get to where we are now. The WFSA in 2020 developed and published minimum capnometer specifications. And these were based on the existing International Organization for Standardization, or ISO capnometer specifications. But these specific specifications developed by the WFSA recognize that many factors constraining the use of capnography in resource-poor settings exist, such as cost, durability of device, availability of consumables, lack of dependable power, and maintenance. And the hope was that these specifications might help guide industry and stakeholders interested in development and investment specifically in this area. The other group I want to highlight is GCAP. And Angela kind of mentioned the group, but this is the Global Capnography Project that was really led by Ellen O'Sullivan and David Whitaker. And they were doing excellent work in Malawi, evaluating the prevalence of capnography in the operating rooms there. And at the time of that study, only 1 out of 31 operating rooms across 7 hospitals had capnography prior to the implementation that they did. And I think that's really important because I think most countries probably in LMIC are in the same situation. And they were really the first to show the feasibility of introducing capnography. Everybody said it was too complicated into a low resource setting, and that its introduction could improve early recognition of critical airway events. The other group I think it's really important to mention is UCSF, and specifically the work that was started in 2018 by Mike Lipnick and his team. And he was working with Mazar Nourian from the University of Utah. And they were actually working to develop an affordable context-appropriate device specifically to be used in LMICs. And they have been doing some interesting work in that space as well. It wasn't in 2020 that the SmileTrain Lightbox Safe Surgery and Anesthesia Initiative was launched. And this multi-year program aimed at elevating the quality and safety of cleft and pediatric surgery within the SmileTrain Partner Network. It was this that laid the foundation for the work that we're seeing today. One of its main programs was the Lightbox Capnography Project, which really was aimed to find a capnography solution for resource-poor settings that would meet the needs of the Smile Train partner hospitals, monitor children requiring airway or cleft surgery. But we understand this need is much greater. And while we used the efforts of this group to really plant the seeds and help us develop and find a device, really, we need the whole global anesthesia and surgery community to come together to really make sure that all settings have this really important patient safety device. Lightbox, with its pulse oximetry experience, was asked to lead the project. And one of the first, and I think most critical things that was done, is it formed an advisory group and brought together all of the key stakeholders in the space that I've mentioned before, and including Smile Train and Lightbox, because I think it was really important that we were working together to really look for a plausible solution. And we also brought together others with experience in capnography, really for strategic guidance for the project. Again, prior to this work, or this advisory group, all of these work groups were working independently, but they weren't really working in a coordinated fashion. So similar to the methodology that Lightbox used to identify the Lightbox pulse oximeter, we approached looking for a capnography solution. And using the WFSA specs that I mentioned earlier, a human-centered design approach was used with input from diverse group of partners actually working in a low resource setting to develop what we call a target product profile. We then created a request for proposal and invited manufacturers to submit a device for proposal, really understanding that if we were able to identify a device that was already on the market, we would save a lot of time and resources. These requests were systematically evaluated, and that's how we chose the device, the Zug device that Angela showed you a picture of. And again, I just want to highlight again, it's a dual parameter device. So while we're talking here about capnography, it actually has both capnography and a pulse oximeter, which we think is really important. So Zippy, that's it from me.
Thank you so much, Dr. Evans, for that update on how much work has gone into this work of bridging the gap. Next, we are going to hear from Dr. Mary Nabukejan from Uganda to tell us how does it look in reality on the ground? What are the things on the ground that we need to know about capnography? Thank you, Dr. Nabukejan.
Thank you very much, Zippy. It's always exciting to be talking about topics like this because as Dr. Enright and Dr. Evans have said, capnography has been in use in high-income countries for decades. But the reality in a lot of LMICs is such that there's a huge gap, and several studies have shown this. In Uganda, we have a more recent study that has shown a gap as big as 85%. And that's not, so many years ago. This is recent information, and you still have 85% of operating rooms and areas where sedation is happening going on without capnography. And we can all appreciate how important this is. And recent unpublished work in country has also shown us that apart from not having the equipment, we also have a gap in knowledge. So the Association of Anesthesiologists of Uganda has over the years been trying to improve anesthesia safety in the country in several ways. But one of the things that we try to do is to influence the type of anesthetic equipment that's purchased by the Ministry of Health for public hospitals. And we all know in our different settings, especially in LMICs, that this is a process that's going to take several years. And so it will be some time before you see significant change because of an abundance of factors that are going to influence that decision for the ministry to actually take up your advice. And one of the things that's significant, especially where anesthesia equipment is concerned, is the significant cost that is added when you want equipment that has a capnograph included. So in September of 2023, Lifebox and Smile Train, in conjunction with the Association of Anesthesiologists of Uganda, conducted a capnography workshop. And this is, Dr. Evans talked about the work of Lifebox to try and bridge that capnography gap. And together with Smile Train, they developed this tool that is, it's steady, it's not as expensive as what's already available on the market. And all those little bits that would be a challenge for a low income setting like ours were factored into this. And alongside the equipment, a course was developed. And so in September of 2023, this was brought to Uganda. And so we ran a workshop together with Smile Train and Lifebox to roll out this capnograph, as well as the training material that has been developed. Over 80 anesthesia providers were trained, both physicians and non-physicians. And for sustainability, we also had to incorporate some training of trainers to help us expand this to the rest of the country. And the workshop was very well received. And following this workshop, we received a donation of over 50 capnographs that went to the anesthesiologists and anesthesia providers that had received this training. So we used this opportunity of this workshop to further our advocacy as an association with the hospital leadership and the Ministry of Health. And so one of the things that we've started to see now is that there are more individuals, both anesthesiologists and surgeons, and also more facilities, both in the public and the private setting, that are now asking about that new equipment. And that's a good thing. So as an association, we find that our journey, continues to push and advocate more with any institution or organization that can help us bring about the change that we need to make anesthesia safer for every patient undergoing anesthesia or sedation anywhere in our different countries. Thank you, Zippy.
Thank you so much, Dr. Nabukenya. It is actually indeed the true reflection of what is happening in many of our LMIC countries. The gap is real, and what the Association of Anesthetists of Uganda has done in terms of advocacy is something that we need to teach our colleagues, work together so that we can achieve more advocacy at the policy-making level for these devices to be more acceptable. With that said, we're going to talk to hear from Dr. Liz Igaga about data and how data can help us make decisions and help us close this gap. Dr. Igaga, you're welcome.
Thank you, Zippy, and thank you to my previous speakers, because they've helped me make my work a lot easier. So when we look at the role of data and the role of research in distribution of capnography across the globe, I think that I'd like to approach it in 3 different phases. So there's what we know so far, and my colleagues have done a wonderful job in explaining that. We know that, that Dr. Angela told us how useful capnography is. We know that we have a gap. Dr. Nabukenya has just highlighted on that. And basically what the definition of a gap is, we expect that every place where someone's having a general anesthetic or deep sedation has access to a capnograph. But the reality on the ground from the research and the data that we have shows that we have, between 50 and 100% of those places across the globe in the LMICs especially do not have access to this. We also know that we've got barriers, and again, this has been spoken to. We've got cost, lack of context appropriateness of some of the equipment that's available, and training. But I'm also glad that now, apart from knowing that stuff, the research that we've done and all of that has led us to a solution, what we think is a potential solution, which is the piece of equipment, the Smile Train Lifebox capnograph, which is actually a dual monitor that has a pulse oximeter and a capnograph. And it's great because it's low cost, it is a portable machine, it is robust, and it's suitable for kids and children and pediatrics in the LMICs. So that is what we know based on some of the data that we have and some of the research that we have. But what do we want to know? We want to know the scope and the scale of the problem globally. And recently, at a trip from one of our partner countries, we learned that while in some places it is the law that certain standard monitors are available, their availability is not necessarily as obvious as we think it is, even in some of the higher resource settings. And we also know that what is not measured cannot be improved, and what is measured gets done. So what do we want to do? We want to make sure that we know what the problem that we're dealing with is as a baseline globally. We also want to know what the impact of what we're doing is from an implementation point of view. We also want to use this baseline data that I'm going to talk about in a minute for monitoring and evaluation purposes. Dr. Nabukenya just said it's going to be a few years before we see impact, but we have to be able to measure that impact for us to know whether we are actually making a difference or not. So the question is, how do we do that? Currently, Smile Train, Lifebox, and the World Federation of Societies of Anesthesiologists, alongside all the partners that Dr. Evans mentioned, are in the planning stages of putting together a project, which I hope eventually will be the coalition that Dr. Angela spoke about. And what we want to do is go around the world and quantify as best as we can the global capnography assessment gap. So why do we want to do that? Data is necessary for us to visualize the problem. So everyone on this call, anesthesia provider or not, basically has been sold on why capnography is important. The question is, do the people who make the decisions actually know that? So we need the data to help us tell a story. We need it for advocacy. And in terms of advocacy, we want to go to the government, we want to go to multilateral organizations, but we also want the ministries of health and the teams on the ground to know what that is, what's going on. And also in terms of partnership, Smile Train Lifebox, the World Federation of Societies of Anesthesiologists, cannot do this alone. So the only way that we're going to be able to do this is to be able to show cause and reason why these other organizations should join us. And at the end of the day, what we hope is that you and I and all the partners that we have with the data that we have will join hands and bring capnography soon to a place near you. Back to you, Zipi.
Thank you so much, Dr. Igaga. We really need to fight the data so we can make a difference. And now we are going to hear from Dr. Haylock. What need is there for global anesthesia guidelines to be updated if we are to see a shift in capnography being recognized as an essential monitor? How do we take these to the next level of guidelines? Welcome, Dr. Haylock.
Bueno, muchas gracias. Buen día a todos.
Thank you very much. Good morning to everyone. I want to start by thanking Lifebox invitation and because they have given me this opportunity to represent the WFSA in this Capno Week. And of course, thank you for your question. I think it's vital to ask this question. I think it's crucial to update the international standards for anesthesia in order to include capnography as something essential. And that way we can change the health policies worldwide. Some recommendations for the access to capnography. Well, one of them is this update of the international standards for safer anesthesia. The WFSA, along with the WHO, they elaborated or they drafted these standards in 2018. They were published, and they included pulse oximetry and capnography. It's important to see that in these international standards, the WHO does not use the term mandatory or compulsory, but rather they use the sentence like highly recommended sentence as something to make it more functional. We can quote here that in these international standards from the WHO and the WFSA, if a esophageal tube is used, we need to do the auscultation, and this is highly recommended. And the recommendation of the proper position of that tube with CO2, which is capnography without or by colorimetry, is also highly recommended. And capnography with the wave is highly recommended whenever appropriate devices are available. In the document, the manufacturers are encouraged to use this, and this is where we are right now. On the other hand, and moreover, the International Standardization Organization, the ISO, is also establishing recommendations, and this was in 2018, recommendations for the manufacturing of capnometers, ISO 86255 of 2018. There are many organizations all over the world, all over the continents, that are backing capnography and have done this. There are international, local, regional, international, world, regional, or societies, medical societies in general, of clinical specializations, and, for example, pediatrics, obstetrics, cardiology societies, societies in general, paramedical societies, research societies, as well as organizations of quality control and evaluation of health systems in hospitals, as the Joint Commission, the Veteran of the US, etc. I can go on and on with many, many organizations backing the use of capnography.
Also, the WFSA published in 2021 the minimum recommendations for the capnometer. Gelb and some collaborators asked in 2021 to the industry to reduce the costs and to have a win-win situation through the delivery and design of technology with easy available capnometer with a high durability and a simple maintenance, as well as an economic and simple maintenance of the consumer goods. So that's where we are now at the moment. Those minimum recommendations of the capnometer for 2021 at the WFSA is based on the specifications of the capnometer from the ISO that I mentioned earlier on. Having said this, we can ask ourselves, should capnography follow the same road of pulse oximetry? Because we know that pulse oximetry was the first non-lector device that was chosen when we thought of essential monitoring devices in low resource countries, because it was very simple to use and it could be applicable for every patient. Then the WHO in 2008 or a bit earlier called for a public consultation about pulse oximetry, and they published the report of the meeting and the pulse oximetry project in October of the same year, 2008. So successful, together with a capacitation package in those LMIC countries, that later on Livebox joined this project, and that's how they were able to deliver the pulse oximeters for the patients that had been subject to general anesthesia in countries with limited resources. The pulse oximetry strategy revealed more than 1 decade ago that the anesthesia providers thought that the perioperative use of pulse oximetry was something essential to ensure the patient safety. That was our experience in Honduras in 2012. It was a project implemented by Livebox, the University of Florida, and the Anesthesiology Society of Honduras. We had a zero gap in public hospitals in Honduras, and that happened in August 2012. We had a pulse oximetry per operating room and also in every bed after the recovery. This was something that we were able to do, and very recently we carried out a mapping of the pulse oximetry in Honduras, and it was mentioned that in Uganda they have 85% of a gap. Our gap was 83% of capnographs in the public hospitals.
Thank you.
Unlike
Thank
the
you,
pulse
Dr.
oximetry,
Hillock.
Muchas gracias.
Thank you, Dr. Hillock, and sorry for cutting you short, but we really need to move it along. I'm asking for your contributions. All the speakers, you have done very, very well. I hope this has produced a lot of interest in the subject, and I hope that all of us are willing to be part of this movement to close the capnography gap. What I want to move on to now is a session for question and answers. Before we give our speakers a moment to say exactly one last thing as their closing remarks. So do we have any questions? Please put the questions on the chat. Let's see. There's one person who had asked about the cost of the capnography. The device that Lifebox and Smile Train have come up with costs $1,000 USD. And like somebody said, it's less than the cost of a smartphone. So we're hoping that many people will be willing to donate and also to buy for their facilities. Is there any other question?
Zippy, there's another question. Yeah, there's another question, Zippy, I just saw from
Yes.
Roberto. He asked about measuring capnography under sedation without a tube. Do we have a special, easily accessible device? And I can answer that.
If you want to answer that, yes.
Yeah,
please.
sure. Roberto, great question. Really, it's just the tubing. There is special tubing you can use to attach to the device that allows you to both deliver oxygen and measure end-tidal CO2. But there's also ways to, if you don't have that special tubing, which obviously most folks don't, to adapt your nasocannula oxygen to be able to do that. And we can definitely walk through with folks how you do that. But really the key message is if you are delivering oxygen, you can use the piece of sampling tubing and just place it under a face mask and be able to capture the end-tidal CO2 of your patient. So yes, the device can be used in that way.
And thank you very much. I see somebody else commenting about its use in adult patients. Yes, that will be, it is possible to use it in adult patients. And I was just wondering, is there anybody in the audience who would like to share their experience about access to capnography? Anybody in the audience who wants to share something about their experience?
Ruwa, he's written a comment from Sudan about their lack of access. I don't know, Ruwa, if you wanted to
Lauren, do you want to speak? Ruwa Abdasalam. You can unmute and speak.
Yes, Assalamu alaikum. Hello, everyone. I am Ruwa Abdasalam. I am from Sudan. And thank you for all the speakers. Actually, in Sudan, we have the same problem. The availability of capnography is limited, maybe in some of the private hospital only. Almost all the governmental hospitals, we don't have the capnograph there. We just all depend on pulse oximetry, ECG, and blood pressure monitoring. Hope that Sudan will be okay and the war will end and we can improve our health system and we will have capnography in every theater and ICU maybe. Thank you, everyone.
Thank you. And Mohammed from Somaliland. is asking if there is any program for supporting capnography in low-income countries. And I'll ask maybe Dr. Enright to answer that.
Thank you, Dr. Gatuya. Yes, I wish we were a very rich foundation that had tons of money and we could supply them to everybody, but that isn't the case. And so while we will attempt to fundraise through foundations and other efforts to be able to provide capnographs to those in need, it's a huge undertaking. That's why I really believe that we as anesthesiologists, and particularly the anesthesiology societies and groups in areas and countries where these monitors are not freely available, they really need to be able to advocate to their own administrators at the hospital level and ministries of health on the importance of having capnography and the number of lives that will be saved. As Mary said from Uganda, they have been taking this important topic to their ministries. And that's why I believe having a coalition is really important. If the World Health says it's important to have it, if the WFSA says it's important to have it, if the societies of anesthesiology say it's important to have it, if we get the surgeons and the obstetricians and the nurses on board, there are a lot of voices saying the same thing. And eventually administrators and those who hold the purse strings will have to listen. It took quite a while with oximetry, as Carolina said. It started off with capnography that hardly anybody had them. And then people began to know the importance and people began to recognize how good it was. Now, when we are talking about capnography and we ask to a room of trainees or participants, how many of you have oximetry? Almost all hands are raised and everybody is using it on every patient. And that's where we need to go with capnography. It's taken over 10 years to succeed with oximetry.
Thank you so much, Dr. Enright, for your answer. It is really needs a lot of work. But I wanted to give I wanted to give Mubarak to answer because they are in the same country. And then maybe Mubarak can say what Mohammed needs to do or what they have done in their hospital. Mubarak.
Hi, and good afternoon, everyone. And I am Mubarak Mohammed, and based in Somaliland. And yeah, according to, and actually, so a week ago, I have done a quick survey, the availability of capnography in Somaliland. And then I've got actually also with pulse oximetry. So like 55 operating room have a 9 pulse oximetry. And yes, there was a huge need for Somaliland to get the capnography. And I think this capnography from Smeltram and Life Focus is unreasonable, and I think every hospital can afford it. So what I was thinking, and yeah, this is my plan. I and my colleagues and other friends is to do some fundraising, how we can get every OR in Somaliland to have at least 1 or 2 capnography in everywhere. So 55 operating room, there was like 9 capnography only. And the 9 capnography to 5 million in the whole country. So the plan is, yeah.
Yeah, thank you. Thank you so much. And we are looking forward to working with you and having a plan that works. Nicole was asking on the process. I think we need to really think about galvanizing the support of our national societies so that, sorry, I'm speaking and I'm on mute, sorry. Thank you so much, Mubarak, for your contribution. Nicole was asking on the process. And we say that, like Uganda has done, if we can bring together our national anesthesia societies and include both the physicians and the non-physicians, we can have a strong voice to advocate for these devices to be available. And now, because we have very, very limited time, I want to run back to the panelists so that each of them can give one remark as we go to finish the meeting. And I'm asking them to keep it very, very short, 1 minute, just your closing remarks. And then if you have more questions, please put them on the chat and we'll find a way of getting them answered for you. So over to you, Dr. Enright, your closing remarks.
Thanks, Zippy. Well, in one sentence, I would say build a coalition for capnography wherever you work.
Thank you so much, Dr. Enright. Dr. Evans?
Advocate, advocate, advocate. I agree with Dr. Enright. I think the more we can tell people about the issue and they understand it, the more funds we can raise, and the more we can get these devices out there.
Thank you so much. I love the way you guys are just brief and to the point. Dr. Nabukenya?
Same thing, speaking to the national associations, push and advocate with your ministries of health, hospital leadership, and the surgeons that we work with. Advocate, advocate, advocate. Push for it everywhere.
Thank you. Dr. Igaga?
Thank you, everyone. And for me, it is we need you. We cannot do this on our own. And to that note, Sarah Hamilton in the chat has put a form in there if you would like to join the capnography advocacy working group that is both advocacy and research. Please let us know and we will reach out to you. Help us bring capnography to a place near you.
Thank you so much, Dr. Igaga. Dr. Haylock?
Gracias. Ocuparé las
Thank
mismas
you very much. I will use the same three words that the WFSA use. Those words are education, joint collaboration, and of course the advocacy. The success for any monitoring technology for anesthesia will rely on the presence of an anesthesiologist who is specialized and trained to do so. So this training is crucial. This has to be included in every anesthesia training. And I will finish by saying that the WHO, what they said at the World Assembly is health for everyone. That's their motto. So I will use those words and I will say health for everyone. This means adopting capnography for everyone. Thank you very much.
Thank you very much, our very able speakers. Now we have two things. We have way of raising money for these capnographs so that they can be taken to the places where they're not there. But we also have a resource for teaching people about how to use capnography. And I'll give Kitty a moment to share about these two initiatives. Kitty?
So thanks, Zippy. So we have an online learning course on capnography, which is open access. We would love anyone on this call to take a look at it, and please share any feedback back with Lifebox or Smile Train. We would love to hear. I'll put the link to the chat in just a moment. Back to you, Zippy.
Thank you so much to all of us and to our very brilliant speakers. I don't know whether anybody has any burning issue that they want to say before we conclude from our panelists. Anybody with any burning issue? I don't see a hand. So yes, Kitty.
Sorry, I was just trying to find, someone had said they had something to share. I'm just trying to scroll up in the chat.
Liz's
you
hand
had
is also raised as well, just in case. And then nobody's,
Yeah?
Liz's
Who?
hand is also, Liz Igaga has raised her hand.
Liz, say something. I can't see the raised hand.
Oh, thank you. I just wanted to emphasize everyone all the speakers have mentioned one thing, which is advocate, advocate, advocate. Like I said, we have an advocacy group going that we are in the planning stages of putting together. You will, if you have put your email address in the Google form that's in the chat, we will be reaching out to you. If you haven't, please do. However, after this, we will reach out with an email as well. In case you haven't been able to, please do that. We really, really need your help. So advocacy, advocacy, advocacy is the key to closing this gap.
Thank you very much, Dr. Igaga. Kitty, have you found the person?
No, I can't find them.
I believe it was
Okay.
You found them?
Yes.
Who is
Fiston,
it?
you're still on. Would you like to unmute and say what you wanted to say? They might no longer be on.
I can see them. Fiston, you unmute, hear us?
You can speak?
Yes.
Thank
Yes.
you. We can hear you now.
Okay. I'm Fiston. I come from Burundi, but now I'm currently in China for master's degree in anesthesiology. So I think that all of them, they said that we have to advocate about the capnography or other equipment used in anesthesiology. So I think that sometimes we face many problems because we travel, we go abroad, and we saw some equipment that I hear someone say that anesthesia machine or other equipment used in anesthesia are very expensive. I don't think so. When we consider other equipment used in surgery or neurosurgery are very expensive than we can use in anesthesiology. So I think that we have to take a decision and discuss with our leaders about the security safety of patients undergoing anesthesia. And if we come together with surgeons and all work, we can make a change to a safe anesthesia and surgery. That is what I would like to say, and to invite
Thank you.
people to advocate about anesthesia, especially for people who don't have any pediatric anesthesiology. So I think that after this master's, I would like to appreciate to join a fellowship program, if possible. Thank you.
Thank you so much. Thank you so much. I would like to thank all the people who have been here on this course. Thank you so much for our presenters, because we know that what we were discussing is important for patient safety. We thank Lifebox and Smile Train and the WFSA for the effort that they have done. And they are launching a call to sign on a letter calling for the recognition of capnography as an essential monitor for safe anesthesia ahead of the All Africa Anesthesia Congress in the coming months. We'll be reaching out to all of you to join us as we do this work. Like we have had, it is important for us to advocate and advocate. We cannot do anything less than that. And every opportunity we get to advocate, we must advocate. Thank you very much all for attending. We will be sending you the recording of this email shortly on your email that you used to